everyone. Welcome to Perspectives. I'm Martina, and this is
Lisette.
Lisette. Thank you all for joining in today, whether you're watching video or you're listening on either I was about to say Spotify and iTunes as well. So we are very happy here to have a special guest with us as we continue our conversation around healthcare in America. We have Carmen, and depending on where you are in the video, and she's waving, so everyone that's watching on video, you can see her lovely wave. We've had different people from different backgrounds that will speak or have spoken, again depending on where you are in listening and watching to the content. And Carmen, we really, we want to just get into her background, and she really works on the administrative side of healthcare. And so I know I'm excited to ask you some questions, and I know Lisette it as well, because that's where I think maybe the bulk of people don't always understand all of the administrative things that happen behind the scenes. So before we turn it over to Carmen, Lisette, I'll let you do any welcomes or anything you'd like to do.
Yeah, no, I am really excited. I've known Carmen for quite a few years now, and I think I'm really just excited to kind of learn a little bit more about her background. Like, I know what she's been doing since I've met her, but I just kind of hear a little bit before that. But I think, as you mentioned, Martina, I think it's going to be a really great conversation on more of the administrative side. I know we had talked a little bit about some of the topics that might come up around, just healthcare insurance when you think about like Medicaid and things like that. So it'd be really interesting. I know mental health is another topic that we might hit as well. But I think just to kind of kick us off, Carmen, I'll kind of just throw it to you and let you kind of introduce yourself to our audience and tell us a little bit about you, but just sort of like your educational background, like where you kind of come in and how you kind of landed sort of in the healthcare professional field.
Sure. Well, thank you so much, Lizette and Martina, for the warm welcome. It's good to be here with you. Thank you so much for the invitation and the opportunity to be here and just share some, exchanges on, background in healthcare, but also like, what I'm looking forward to, and because healthcare is in a huge transformational state right now. So thank you so much for helping me also get through the thought process, because I think having outside perspective is also very appreciative, because we don't always know, the perspective from the outside as well. So it helps to inform us at the same time. So thank you so much. So I grew up in Chicago on the Southwest side. I grew up in Little Village and grew up there in almost my whole entire adult life. Lived in Little Village, so it's definitely a place that's near and dear to my heart. I am a nurse by training and went to school at UIC, and then spent a little bit of time there. And then really, as I started to practice as a nurse, which I did for a short period of time, I really started thinking about the prevention lens, like how can we prevent certain conditions from actually happening and occurring. So I really got interested in the preventive public health space. And so I went to the UIC School of Public Health and got my MPH there, specifically in community health and in maternal child health, because that is a special population of interest for me. And after being in the field for a number of years, I found a role at NFQHC here in Chicago on the Southwest side, Esperanza Health Centers. And I've been at the organization for a little over 10 years in a number of different roles. First as a quality coordinator, and then as a director of quality, and now as chief operating officer, and have been COO for the past 4 years. And it's been an incredible ride. I think every year that I've been there, I describe it as dramatically and traumatically different from the year before, just because so much has happened in those past 10 years. But healthcare continues to change, and I'm along for the ride right now, just, trying to make sure that I do what I can to be thinking equitably for our community, and even just really for the city. And so that's where I am right now. And so I'm happy to dive into anything more specific that you'd like to chat about.
Awesome.
Yeah, I saw Martina sort of wave your hands and move your hands up when you said UIC.
Mhm.
Because I know you went there.
I did. I got my MPH as well, and I was policy and administration.
Great.
But almost
Mhm.
all of my friends were all in a community health, so I spent a lot of time on that floor and with that group of friends. So I definitely were definitely familiar with UIC.
Mhm. I think if you are working in public health in Chicago, you're definitely going to be amongst colleagues who also went to the
Oh my
School of Public
goodness.
Health.
Definitely, especially when I was doing my work on the West Side, as most of us, well, all of us
Mhm.
have worked, or you two continue to work on the West Side. I've met so many, like, after we graduated, it was not the end. And so I've seen so many of them, and sometimes there's like a little cohort of us that
Mhm.
are just there. I was like, oh my goodness, I haven't seen you since. So it's definitely, true. And I think as big as Chicago is, it's definitely small at times. It's just, especially once you get your cohort and your group of friends. Well, thank you so much, Carmen, for that great introduction. I did not know that you grew up in Little Village. That's one of my favorite neighborhoods. I'm so excited to hear you say that. But really, I guess, I'm trying to think. I want to, like, should I just dive right into it, Lisette, or what are you?
I think one of the things that I was curious, and this was me thinking on the ride back to the
Yeah.
house this morning. I was kind of thinking, I'd love to just hear from you, Carmen, a little bit about the educational sort of side of healthcare. And particularly because I think Martina and I talked a little bit of like, when you think about health equity and sort of what you kind of learn as you're becoming a health professional, uh, and you don't go get an MPH, right? You don't go and and do that, and you're sort of just
Yeah.
straight into like the nursing field, doctoring things. You know, do you, did you get a sense of there being, as you're learning about, being a nurse and healthcare professional,
Mhm.
like are there biases or things that kind of come through, or just the way that you don't think about culturally where a person is at, where it's not just health isn't just the numbers you might see on paper, but it's obviously your environment, right? And sort
Mhm.
of your culture and sort of things like, are those things missing from sort of the educational system when it comes to sort of thinking of healthcare? Like that's sort of where my head is at. So it kind of,
Mhm.
while it's fresh in my mind, I just want to kind
Mhm.
of pick your brain a little bit if you feel like some of that is missing
Mhm.
when people go into a healthcare field and you're learning and you just kind of learn in a
Mhm.
very, I don't know, white centric kind of lens
Mhm.
versus the diversity that does exist in our country.
Yeah, well, I think, that's a big, a big question. And I think it's a really good, interesting question to ask because as I think back to my own training as a nurse, when I was in the cohort of my nursing group, we were about maybe 85 to 90 students who started together, and five of us were of Latinx background.
Mhm.
And that is just like speaks to the number of people of color who are getting into the healthcare field in terms of the academic side. And we were only five, and it really felt like we stood out for sure. Like I think it was something where I felt the difference in my classroom, where most people just really were focused on like the science behind healthcare, and looking at how do we learn and then sometimes memorize pharmacology and anatomy and physiology. And you have essentially 2 years of nursing of school to learn everything, and very little space to really understand like the cultural aspects of healthcare. There's even little space to really talk about like the leadership role in healthcare, because and many clinicians end up being leaders within their hospitals or healthcare systems, but didn't really receive that type of training in leadership or even really business, because healthcare is a business. It took me a really long time to make peace with that, because as somebody who trained to help people, it was really hard for me to make peace with the fact that healthcare is a business, but it really is. And especially now being in the administrative side, you see that very prominent. So just knowing how many students were allowed to be part of the healthcare system through being able to go through the educational process and being able to then get their licensure once they finish nursing school. And it's the same at med schools and in other allied health systems as well. So that right there is like your first, that the programs are not really built to address that. And part of that also is who's teaching in these courses. So the teaching professors, at this point, it's a requirement that you have a PhD in order to be able to teach a class in nursing school. So if you start looking at and digging into who has a PhD in nursing, that also starts to influence what you're being taught, which also then contributes to there's such few spaces and spots in nursing schools because the programs just don't have enough people to teach because of this requirement that's placed here. So that's a really a systemic issue that should be looked at, because we're really not bringing in sufficient the number of students that are interested in being part of the nursing program because of the limitations in the program. So that's definitely something that I think is contributing to the nursing shortage and the shortage of Spanish-speaking people who identify as Latinx, and just other communities in general. So I definitely think that once you're in practice, because you haven't had the cultural bias into your programming, then of course you're not really looking into what some of your biases, how that might affect the care that you're providing. And so that's something that's very prominent, and it's really hard for healthcare professionals to admit that, because you go into this field to help people, you assume best intentions, and it's true. I think by and large, everybody who I've met in healthcare that's a clinician really has that good intent to want to help, but still hasn't been taught to check their bias at the door, and how and to really understand how biases might affect the care that they're providing. And I think there was a recent study that came out recently that when looking at electronic medical records, the words used to describe behavior for people who identify as Black or who are Black is different from people who are white. So you'll see words more like non-compliant or just words like that are more negative connotation. And so you see that, just from the way documentation occurs in medical charts. And so it's I think the silver lining is that these conversations are starting to happen, and that the healthcare field is starting to look closely at how our biases really do affect the care that we provide.
Oh, Carmen, it was so much there. You talked about like healthcare as a business, but then you also, you're absolutely teaching me a lot of new stuff. I did not know that in order to teach nursing, you have to have a PhD. Has that always been the requirement, or is that something fairly new?
I'm not 100% sure. I do know that if you want to be, if you want to teach in the classroom, that's the requirement. But if you are on the floor helping and precepting a student during one of their field practicums, that's not a requirement there. So that allows for you to be able to teach like in the hospitals, because students do have to have practicum and they have to be able to have that time with patients, and that's not required. But in the classroom, that's where it is.
And so do you feel that's been a hindrance to maybe students of color, or, because, I think you touched on, it is nice to see people who look like you, identify with you, or have that similar background. So have you, seen that, or just, when you were in school at that time, did you notice any kind of differences among the students of color who were pursuing a nursing degree?
I think so. I think that you are walking into a classroom with sort of your guard up, like not sure like how much you can share in terms of like what your experience, your background is, and how you viewed the healthcare system. I think that's always something that's not really discussed, or that space isn't created in the classrooms. And I think that you're eliminating one, because programs are created to so that you learn as much as you can in the shortest period of time.
Mhm.
So you're really focused on sort of like the science behind the persons and their you know, their clinical systems, but not really like, you know, the whole being. And that's, I think, where there's a huge miss just in like the healthcare programming, educational system in general, where there's like this rush to kind of get students through the program, but then you miss all these other factors that contribute to someone's well-being. And I think there's definitely a miss there. And yes, I think part of the biggest hindrance is that there are a lot of people who are interested in going to nursing school. I work closely with medical assistants who really want to go to nursing school. They want, you know, to be able to advance their education, but there are very few spots for them to take. So it does get pretty competitive to get into nursing schools because you have very few spots that are open. And so they do sort of take like the cream of the crop, like that, the highest, you know, students. And of course, we know that there are so many reasons for why some people are the cream of the crop. And so I think that that is a big, you know, that's a problem there. And when you look at the interest, people want to go to nursing school, and the spots are just not sufficient to make up for the people who are retiring or for the people who are leaving because, you know, they're burned out or whatever it might be. And so that cycle, it's just like perpetuating itself for there to be a continuous cycle of a nursing shortage.
There's so much that's not even taken into consideration. I'm fascinated. I would say that I'm shocked, but I'm not shocked to hear that. Well, Lisette, feel free to jump in and ask some questions.
Yeah, no, I
A
think
lot here, yeah.
there's just so much to digest.
I know there's so much to unpack from what you just said in this short amount of time.
One of you know, I think about sort of when I think about nursing, I remember when when I was in high school, just a few years ago when I was in high school. But I remember like sort of the targeted audience was sort of, Latinx and Black, students to be like, pursue, a healthcare profession, pursue, start as a medical assistant, then you can get to being a nurse. But to hear that there's this sort of pipeline that's very little to get to nursing, like I never even knew that, like even to this day, like I didn't realize how coveted maybe like the spots, and how little they are, like, because I remember that was sort of what people were saying, like, hey, you can start as a medical assistant and then you can become a nurse and you'll be making so much money. Like that was sort of just what you heard. Like, I remember people were pushing me and I was like, I was like, I knew I wouldn't want to be in the health because I was blood and all of that is not my thing. But I had friends who tried, who went, I had people that I knew that were like, well, maybe I'll try it out. And it just became hard because they're like, it's so competitive that if you don't get certain, scores or grades and you're not getting that and you're not showing, like, I think about like a law school, right? Like there's so much you have to get in order to get to those things. But it's like, I didn't realize that. And it was just one of those things where I remember, and I still think that that field is targeted towards, Black and brown individuals to like pursue. But if you don't
let them in.
Right.
Yeah, and typically women, and it's like, but if you don't know what's on the other side of the curtain, like, are you're gonna be disappointed and you're gonna, be upset. So yeah, that was just one of the things that just kind of came to mind as you were talking, Carmen, because I was like, oh my God, we were targeted to get into these fields. And I see so many, Latinx and Black individuals as medical assistants.
Yeah.
But I don't see them in the nursing realm. And I kind of get a glimpse.
Yeah. And you always hear that, oh, we have a shortage. There's a shortage of nurses in the field. And now, you understand more listening to you as to why do we have this shortage when we could definitely be closing this gap. But it doesn't sound like that's happening yet.
I mean, that's like a whole other conversation about investment in higher education and where do you start and how do you create these pipelines to give folks the opportunity to have a place in nursing. It's a very rewarding place. I think, most people, they want to be able to help people. They just really are intrigued by, and of course the science behind it, but also wanting people to be healthy. And it's a very respectable field. And I think people do have pride and joy in being a nurse. And the pay is also like fair living wage, of course. And so I think that we're missing an opportunity there to really address the healthcare needs of an aging population, and the living wage situation for so many Black and Brown people. And so I really hope that that's part of the healthcare transformation that we're in the middle of right now.
And another thing, when you said, you have to have a PhD to teach sort of in nursing, and I think about like the pool of Black and Brown individuals who go and pursue a PhD, or who are able to pursue a PhD, because that is a commitment. Like, I think I know very few Black and Brown people who have PhDs, like in my circle, and I mean, and it's like, I can't even imagine, like, because if you don't have, that Black and Brown perspective in that field, teaching it, then how do you even change sort of that educational, kind of system to kind of start including the cultural thing when you don't have that pool of people to also be able to do that? It's just another thing.
Yeah, and I don't think it's necessarily unique to nursing.
Right.
No, right.
Which is something that also I think is really telling about, I don't know about like beyond healthcare, but in public health, it's similar. You do have that PhD to teach, and that's also problematic.
That's so true. That's so true, because a lot of individuals have the PhD, or they have a DRPH. That's like another one. But that's so true, because now that I think back through some of my training, and even some of my peers, some of them have gotten PhDs. But again, I can count on one hand how many of them of color.
Yeah.
Which again goes back to this systemic issue. Yeah.
Oh, that was just such a good sort of
opening. That was a really good.
You don't, and that's why I'm glad I asked the question, because I was like, I wanted to kind of get that perspective in, and the thing that I think you mentioned when you said healthcare is a business.
Yes, that's it. That's
something that I know. I was talking to Martina about like how I'm starting to grapple with that, and sort of understanding and being sort of enraged by it, but also like, okay, what? Like, there has to be something we can do, because with kind of going through this healthcare kind of crisis with my dad, who, if you all don't know, the audience, like, he fell a few months back, and he's sort of been had surgeries in the hospital, and sort of the nursing rehab center he's at now. But looking at sort of, there was a story I told in another episode where he had an appointment, and my sister took him, and they were like, well, he has a balance from like 2014, so we can't see him unless you pay that balance. And I know my sister called me, she texted, she's like, I paid it, but I was like, we didn't even know about it. And it's like,
it wasn't even $200, was it? It
was like, it wasn't
even,
it was like 100 or 150, and it was just one of those things where, like, you see a person as a dollar sign, right? And particularly if you look at the private practice and hospitals, and I know there's FQHCs and their free and triple clinics who kind of have that sort of safety net for people to be able to afford. But even then, like, if something major happens to you and you have to end up at a hospital, you still have to pay a significant amount. And it's like, and it's just these last few months where I've grappled with that, and that healthcare is a business, and how even when you have health insurance, just the different loops you have to like jump, and hoops you have to go through to get something covered, or like, I was like, especially if you're underinsured. If you're underinsured, that is, I think, and that's where my dad was at. Like, he's just had Medicare, and it was like, well, he can only be here for this long, or if he doesn't meet this requirement, he won't get covered. And I'm like, what are you talking? He is an elderly man. Take care of him. That's all you have to do. But it wasn't there, because there's this lens of you know, it is a business. But I want to dig into that. So I just wanted to kind of share a little bit of that for me of what I've started to see and kind of
Mhm,
grasp on my own, you know, experience with healthcare.
mhm. I think maybe a place to start, which is usually like a workshop that I'll do with some of the new staff members who join us at our FQHC, because I want them to also have an understanding of why we do things the way we do, the reasoning behind it. And often it's because, there's a lot of, financial reasons why we have to do things in a certain way. So one of like the biggest, at least when I first started, was that our medical visits are 15 minutes long. And I always wondered, like, why 15 minutes? Like, why is that the amount of time given to a medical provider, or, a nurse practitioner to work with a patient? Like 15 minutes goes by so fast. And it turns out that for the most part, 15 minutes is the most that you can give to really meet the bottom line of the day. So when you have somebody who's working 8 hours, you divide that by 15 minutes, that's X number of patients. So that's the amount that the number of patients that you could bill for based on how many patients have insurance. So when you get that revenue in, because you submitted those insurance claims, that revenue helps pay for the salaries, it helps pay for the light, the gas, the supplies, everything that goes with operating a clinic or a hospital. And so if you deviate from that 15 minutes, that does then affect your bottom line because you're seeing fewer patients per day. And so that's just really a math problem. And so that's something that's very little wiggle room to change that, because otherwise you're going to have to cut somewhere. And I think one of the biggest issues is that most insurances, they only pay for certain things. So they'll definitely pay for a clinical provider to do an evaluation on you. They'll pay for certain medications, but they won't really pay for the services that surround the patient and give the patient the opportunity to be healthy. So, for example, nursing, it doesn't get reimbursed for us as a community health center. So we have nurses do work, but we can't bill for the work that the nurses do. So that right there is a value statement. What insurances are willing to pay for? They're willing to pay for the doctor. They're not willing to pay for the nurse. We also don't get paid for community health workers. So we have community health workers who are out in the field, enrolling patients into benefits. They're doing a lot of HIV prevention and outreach. And those are services that we don't get paid for. We have to go out and look for grants to help us, subsidize those positions. And so if you really narrow down to what insurances are really willing to pay for, it's just certain services. And it really is really telling about, what services they value. And even if you go to the hospital, if you ever get an explanation of benefits, you see all the line items of the things that they're charging you for. You won't see nursing on there, because nursing isn't a line item that they'll cover. It's sort of like just part of room and board, but you'll see the physician's name on there. You'll see x-ray, those diagnostics, but you don't see nursing services there. But that is a major cost, and it is a big part of the care that's delivered in hospitals. So even if you look at how the structure of reimbursement, I mean, there could be entire classes on how insurance reimburses for services, but that right there is just kind of some of the factors that we have to take into consideration when creating a budget and what we're allowed to do during the fiscal year, because we know what services will get paid for and which ones we won't.
Carmen, oh my God. I mean, I already think insurance is trash. I mean, and the thing is, but I am fortunate enough to have insurance. So I should say that I'm very fortunate. But so if items, regarding nursing and other services are not included, who's paying that? Is it the organization? Is it the patient? Is it both?
Well, that's why you have 15 minutes per patient, because you have to also use whatever overage you have to subsidize the care that's being provided.
Wow.
And there's also, we have private, funders, who, philanthropic organizations that, we apply for grants. And then in our case, for example, we're an FQHC, so we get funding from the Health Resources Service Administration. So those are guaranteed dollars that we get, and that helps us subsidize also care for uninsured patients, because the cost of care for us to deliver for every patient, regardless of insurance status, it ends up being about $140 to $160 per visit. But a patient who's uninsured, we have to, that we offer them a sliding scale fee, and most patients qualify to pay $30 per visit. So we have to then use those dollars to cover the rest of the cost of the patient's care. So a patient will pay $30 for their care, but it really costs us like $140 to provide care. Once you take into consideration the cost of the salaries, supplies, and just like all of the technology, like laptops, just all the stuff that's part of the operations. So we always have to be able to predict almost how many patients we're going to be seeing, so that we understand what will be coming in and what won't, and also so that we can inform grant funders and say, like, this is what we have enough for, this is what we don't, but we really need it because this makes an impact on the patient's care. So those are all the behind the scenes things that are happening that you don't see like at the front desk, and you don't see it in the exam room. But making the bottom line meet is really like the responsibility of like the administrative staff to make sure that we're operating, that we're open, that we're not going bankrupt.
I said, I see you want to jump in. I was like, I know you want to jump in. I saw you, like, she's probably writing down, like, I want to ask her.
I put like structure of reimbursement because it's such to hear that, nursing isn't a line item to reimburse, but nurses do so much. Like, I was like, the doctor sees you for like this, but your care, like, when I think about in a hospital, like, it's the nurse that comes in and and checking you, and it's usually they're the ones checking your blood pressure and doing all these things and recording your numbers and all, and so it's just sort of, that's why I was like, my mind is blown by that, just even that thing, because I know how much nurses do, with kind of just knowing a lot of you, and it just kind of, and it's like, wow, for especially like when I think of like an FQHC, your community health centers, having to go and get those private funds and those grants to kind of just
piece it together.
To be able to like ensure that you have the staff that you need, that you have everything you need, because you're only reimbursed for this thing, because insurance is just it's just a small portion. So like to understand that, and even as someone who was involved in the FQC and not really understanding sort of like, wow, there's this huge, why we're pushing so hard to raise these funds, like I quite never understood. Maybe it was my fault for never really asking or kind of doing that, but I was like, oh, now I get it, like this is why, because you don't hear again, that's why I'm so grateful that we're having this conversation today, because I'm learning so much about what it takes to even run just a
business, like the business
side, just the business side of things, to even be able to provide the care that you do. And I know the health center that you're at, and sort of the quality of, because then you have to think about the quality of care, and now I understand why there's so much differences in quality of care throughout, depending on communities, even the health center you go to, because if you're not able to meet or able to raise or get the funds to cover things, something has to give, right? And I think about that, and I'm like, so my brain is just processing everything.
Yeah, I mean, it gets even like deeper, and I think there's only like this certain like level that really, that I think I see from like my perspective, but it definitely goes even beyond that. But this we always have to make ends meet, and also be like an economic, engine. Like if we're an organization and we have 300 staff members, we want to be a good employer. We want to make sure that we're offering living wages. We want to make sure that we're offering benefits, just so that everybody feels like, I can do my best during these hours that I'm at work without worrying that I don't have insurance, or without worrying that I don't have a 401k that I'm contributing to now. But really, aside from like the provider and the nurses, we also have to find the dollars to pay for our call center, and to pay for our front desk, and for like the training team, just to make sure that all of those folks who are part of the system, who are part of the care team, also we need to make sure that we're taking care of them, because we can't operate without them. And so as an FQHC, we are considered a safety net. And part of our status, we get funding every year to run and operate. And part of our requirement is that we see patients who have Medicaid. So private, offices, they don't have to see, anybody who they don't want to see. So oftentimes they will turn away patients who have Medicaid, because the reimbursement isn't the best, and they don't really get reimbursed in a timely fashion. They'll get reimbursed months and months after the fact. So when certain places can turn away patients with Medicaid, that begins to limit where they can seek services. So you see a disproportionate number of patients with Medicaid going to those places that are already the safety nets, the places that are under resourced just by nature of being a safety net. So you start to see that they fall into care at places that have the least amount of resources to provide that care. And so that really also becomes a slippery slope in the ability to offer high quality care when you have such a huge volume of patients who are coming to see you because of the insurance that they hold. So it's just, it turns into this like just snowball of just inequity that ends up with the patients.
Carmen, you hit on like, Medicare and Medicaid, which I think a large percentage of the country, we have people who have either one or the other, or they are dual. And you mentioned something about for those clinics who can turn away those patients, and it just makes me think about patients who maybe have to wait, or who are waitlisted, and how that, I think, again, going back to that quality of care. And just I'm thinking about my own situation with my father, who is currently having some eye issues, and he has Medicare and he has Medicaid. But because of where I found him, actually an appointment, because it was taking forever to get him in someplace. And the one place that I was trying to get him into, they didn't accept Medicaid, but they accepted his Medicare. And so somehow he ended up there. Well, he ended up there because my sister brought him there, but because he didn't have his card, they wouldn't see him. And so my sister had to go through the process of trying to get him another card. That's going to take about 4 to 6 weeks before it arrived. And so she ended up getting she got the letter in the mail saying that the card is coming and has his information. And she actually called the eye doctor back. And it's like, the card's on its way. I have the letter saying that it's coming. Can we make this appointment? And they said no. They want the actual card for him to have it. And I found that so bizarre. I've never really encountered that. And I remember telling Lisette about that. And, I have my own opinion about this private place. And, I think there are other reasons as to why he could not make his appointment. But it just made me think of that, and how, private clinics, they have that option where it's like, and I know they told my dad, well, we can still see you, but it's going to be $300. And that's just for a basic consultation. That's not even to tell him what's going on with his eyes.
Yeah, it really is hard. And it's probably this clinic trying to protect themselves, because if they see this patient where they don't have actual proof, the insurance company will deny that claim, and they are just unwilling to take that risk. And then who is the person who gets affected? The patient.
Yeah.
It's like the patient who carries that burden of the systems just not being efficient, and the private office saying like, no, we're not willing to take that risk. And they have the ability to like turn somebody away. It's not right. But that's really what you describe there is what's playing out. And they're just like, no, we want to make sure before we move forward. And it's just like, that's not how healthcare should be.
Well, I love what you said. That's not how healthcare should be. Because I think that's been what I keep saying. Like, how is this the world that we live in, or the society that we're in here in the United States, where you know you want to get the care, especially as someone who's sort of, you know, the one that takes her parents to appointments and does this, and I, you know, share that responsibility with my sister, and it's interesting. I think I shared a little bit that my sister never really understood sort of what the healthcare world is, and I've had glimpses of it because of the work that I do, and just to see her kind of like understand and come to the realization that our healthcare is, and it's, I mean, just to kind of put it bluntly, like, it's just trash in a lot of places. Like, it's just, you know, just the access to it, and just the barriers that are put in there when you are uninsured and underinsured, and you add on top of that you're a person of color, you know, you add on top of it that you might not speak the language, and you have all these barriers that are coming through, and then you know that there's biases of like people wanting to, you know, who just see you and they're like, oh, that person probably doesn't have the healthcare coverage that would, you know, cover everything, and, you know, let's just deny it, and all these things. So it's just so um it's been eye-opening, but even just to hear you talk, Carmen, about just sort of the behind the scenes, and what's kind of been happening, what happens behind the scenes, it's just been such a learning journey for me to, right, just to the last, you know, like, I don't know, like half hour that we've been talking or so, like, it's just the small amount and just what I've learned, and then kind of just seeing that just gives me so many more glimpses as to what are some of the bigger issues that I didn't know existed. I just assumed things, but you know, not understanding it has just been crazy. It's like, that's all I can say right now.
I know it has been very mind blowing. I think Lisette, you touched on something too, but Carmen, you brought it up earlier about looking at the electronic health records and seeing how they describe a Black person. Yeah, I don't know if you use a combative or a non-compliant. It was, I think that was the word. And it's again, like, it's almost like you hear about these things, but it's like, until, like, you know, actually hear it come out of your mouth, that like, wow, this is really, you know, to me, that's just a bias, you know. And again, I think going back to the training that should be happening in nursing schools, medical schools across the country, they should be getting this real life experience and dealing with all different sort of patients. And just to hear that, you know, that's how they would describe someone of color, it's just really, it's really, again, mind blowing and very upsetting. It just makes me wonder, would they use that same descriptor for a person who was not of color?
Yeah, I mean, I think it's like the first study that I've seen that has looked at, it didn't say where or what institution or what health entity it was, but it's, I think, a first look at how folks document and what their perspective is on the behavior of somebody, whether or not they follow the recommended treatment plan, without any indication of why perhaps they chose not to follow that medical plan, because there's a lot to dig into that. But then again, with 15 minutes to do that work, you're also limited with that. And I think by and large, I think the intent is to be able to do right by the patient. But then if you have some other structural limitations that don't allow you to really also dig deep, I think you're kind of looking at surface level of the patient rather than digging deep into what really could be happening. But then that's why you also have a care team. So that's something that like a community health worker could definitely drill into and, you know, connect with the patients and, you know, be able to, as a peer, to understand, you know, why they might have some apprehension for a treatment plan that's recommended. And so that's why you need like the entire team to help be part of the patient's care, but then that reimbursement isn't there to have a sustainability, because you might have a good team of community health workers, but if the grant funding runs out, then you have, you know, you don't have that consistency there. And of course that's problematic as well. And so there's just like so much that could be done to untangle all of this to really look at the patient-centered approach, which is what we're asked to do over and over and over, but have all of these barriers that really don't allow us to do that.
Mm-hmm. I think that's a good place where we can pick up in part 2 of this. So yeah, Carmen, thank you again. We're gonna start to transition over into part 2, but just want to thank everyone who is listening and watching this. This, like I said, this is really, really, really good things to hear. Yeah, I'm kind of dumbfounded right now. So listen.
No, I think this is a great spot to kind of end on sort of like that patient-centered approach, and I think we can pick that up and what it really means and what are some barriers to that, and what does like health equity look in general. I think those are things that I've been kind of grappling through this conversation and thinking of like how to continue. But Carmen, again, thank you for being with us and sticking around with us for a part 2. Those that are listening, thank you for tuning in. We will be back with another episode with Carmen, so stay tuned and keep an eye out for that. Please make sure to subscribe so that you're notified when the next part comes up. If you have any comments, questions, you can reach us at Instagram, and we have a Facebook page now, so make sure to kind of follow those two so that you are kept in the loop and can reach us, and any thoughts or topics that you'd like for us to explore in the future, please let us know. But again, thank you all. Thank you, Carmen. Thank you, Martina, for just kind of helping us navigate this conversation too. So thank you, and stay tuned, and we will be back.
All right.
Bye, everybody.